Now we move on to examination of the heart and jugular veins. To do this, you need to position your client in the most comfortable position for them. This is usually reclining on a couch in a supine position or at about 30 to 60 degrees of the upper body. From this point on, to examine the heart and the jugular veins, you need to get your patient in the most comfortable position for your patient. Ideally, this should be lying on a couch at around about a 30 to 60 degree angle of the upper body. Over here, we've got an examination couch, which unfortunately isn't ideal. You're not going to always have ideal conditions, so we're going to jury-rig a comfortable position with the patient here, Ian. So Ian, what we'll do is we'll stack a few pillows here, and I'll ask you to get up on the couch, if you can for me, and then lean back on the pillows. Are you comfortable there?
Yes.
You can breathe all right?
Yes.
Good. Some of your patients are not going to be able to recline supine. Some of them are going to have to sit bolt upright, and you're going to have to cope with these eventualities. As inspection and palpation reinforce each other, it's best to do this part of the examination together. You should arrange tangential or oblique lighting, as this reinforces and improves your ability to observe pulsations. So I'm going to shine a light on Ian's chest. You tell me if this gets too hot, Ian. Mm-hmm. And just inspect the client's chest. See if you can see any abnormal heaves or pulsations in the client's chest. Happily, we can't see any for Ian. Next, we're going to locate and then mark on the patient's chest the major landmarks for examination, inspection of the heart. This, of course, will be done with a water-soluble ink pen, and it's not entirely necessary to always do this, but when you're first starting, it's a good idea. Okay, Ian, what I'm going to do is feel around your chest and the ribs on your chest, and then mark it with a pen. Mm-hmm. First, you need to find the sternal angle. This is a very important landmark because it marks where the second ribs join the manubrium on the sternum. First, you need to find the suprasternal notch where the clavicles both join the top of the sternum or the manubrium. Then you move your fingers down or palpate down the person's sternum, and for about 2.5 centimetres generally, and you'll find a protrusion or protuberance that is quite readily palpatable. And then this is where the two ribs join the manubrium. Move your fingers out along that second rib and find the space underneath that second rib. The spaces underneath each rib are named for the rib above them. So the space below the second rib, obviously, is the second intercostal space. Find this second intercostal space on both sides of the sternum and mark it with the pen that I spoke of. This will wash off later on, Ian. Okay? Mm-hmm. Next, count down from the second intercostal space and find the third, then the fourth, and then the fifth intercostal space, and mark it on both sides of the sternum. It's most important to know where it is on the left side of the sternum, and we'll talk about that very shortly. Next major landmark you've got to find are the two ends of the clavicle, the medial end of the clavicle where it joins the sternum, and the lateral end of the clavicle where it joins the cranium. Find the middle point between these, obviously it's the midpoint, and draw yourself a line down the person's chest, either in your imagination or as we're going to do in reality. Again, I reassure you these are going to wash off. Then draw yourself a line across from the fifth intercostal space, and this intersection should mark where the apex beat of the heart can be felt. Now that we've marked all these landmarks on Ian's chest, we'll inspect and palpate them, and I'll talk about which areas we've marked as we go through them. Ian, what I'm going to do now is palpate or feel over each of these areas and shine a light obliquely, as I said, over them. First of all, we'll look at the apex beat area. You should, in some cases, see a little bit of a heave or pulsation there, but in the healthy client, no. As in Ian's case, we don't see any heave or pulsation there. If somebody's got a little bit of left ventricular failure or a huge cardiac output, for example, if they've got anemia, they're heavily pregnant, you may see a left ventricular heave at this point, the apex beat. These landmarks obviously lie above specific areas of the heart that we are interested in investigating through either inspection, palpation, or auscultation, all of which we will do during this video. The area here on the right side of the sternum in the second intercostal space should hopefully be just above the aortic area of the person's heart. The area over here on the left-hand side of the sternum in the second intercostal space should be just above the pulmonic area or pulmonary area of the person's heart. Here in the fifth intercostal space on the left side of the sternum is around about where you'll find the tricuspid listening area or the right ventricular listening area for the heart. And then over here in the point of maximal impulse that we've marked off is where you should palpate the apex beat and hear the mitral valve. This is the left ventricular listening area. What we're going to do now is palpate the person's chest and see if we can actually locate the apex beat and then compare it to where we reckon the point of maximal impulse should be. To palpate for the apex beat, use the ball of your hand at the base of your fingers first of all, and you will detect any thrills or vibrations if they exist. And then to locate it more accurately, use your fingertips. These are the more accurate tool for finding pulsations. In Ian's case, I can feel his apex beat just about there. So I'm going to mark that yet again. What you need to do next is grab yourself a ruler and measure how far away from your estimated apex beat or point of maximal impulse you have actually detected the apex beat, and Ian's lies not very far away at all, indicating that he has no problems with his left ventricle at the moment. Having palpated and inspected your client's chest, you need to move on to auscultation, which we're going to do now, Ian. So you take your stethoscope and place the diaphragm of your stethoscope over the mitral listening area and listen to the normal heart sounds. At the same time, palpate your client's pulse. Now the first heart sound occurs just before systole, so it will precede the pulse, which is happening here. Next, move on to the other listening areas and see how you can hear the different changes in the valves as you move through them. The aortic listening area on the right side of the sternum in the second intercostal space is next. Then the pulmonary listening area, second intercostal space, the left side of the sternum. The mitral listening area we've already spoken about. Then down to the tricuspid listening area, which in most people you will hear best in the fifth intercostal space just to the left of the sternum. If your client has an enlarged left or right ventricle, but particularly right ventricle, you may hear the tricuspid listening area best over on the right side of the sternum, but in the healthy individual, like our client here, it's heard best in the fifth intercostal space on the left side of the sternum. The splitting of these two heart sounds is difficult to hear. However, by asking your client to take a large breath in, Ian, take a large deep breath for me, and out again. Thanks. You may be able to hear the splitting of these sounds, particularly the second heart sound. Inspiration increases the volume of blood in the right side of the heart and further delays the closure of the pulmonary valve. Two additional sounds which may be present are the third and fourth heart sounds. They're quite low in pitch and need to be listened to with the aid of the bell of the stethoscope. When using the bell, remember to place it lightly on the chest wall. Otherwise, the stretched skin is going to obliterate these low-pitched sounds. The third heart sound is caused by rapid filling of an abnormal ventricle, such as in heart failure, and can be simulated by the word Kentucky. Ken and tuck representing the first two normal sounds, and E, the third abnormal sound. It sounds a little like this. The fourth sound results from atrial contraction and may also be suggestive of cardiac disease, such as heart failure. This sound can be simulated by the word Tennessee, ten being the abnormal fourth sound. For a detailed review of these sounds, there are a number of audio tapes available which describe these sounds. Other abnormal sounds that you may hear when you're listening to your client's heart are called heart murmurs. Blood flow through the heart is usually quite smooth or streamlined, but if it becomes impeded in any way, then the turbulent flow that's produced will produce heart sounds called murmurs. Of course, blood flow is normally quite smooth, but it can become turbulent when it's obstructed. Probably the two common causes of heart murmurs are valve abnormalities or unusual holes in the walls of the heart, such as a ventricular septal defect. The two most common valve abnormalities that you're likely to come across are, first of all, a narrowing of the valve, preventing outflow of the blood, that we call stenosis. And the second abnormality is an incompetence or floppiness in the valve where it doesn't shut properly and we get regurgitation of blood back into the chamber where the blood originally came from. Here's what mitral stenosis sounds like. Notice that the murmur occurs during diastole, after the second heart sound. Blood normally pushes this valve open during diastole and flows into the left ventricle unimpeded. Narrowing of the valve causes turbulence during this period. Mitral stenosis is described therefore as a diastolic murmur, which is naturally enough best heard over the mitral listening area. Try and think through the cardiac cycle and estimate where the murmurs produced by the following pathologies would occur. That is, during systole or diastole: aortic stenosis, mitral incompetence, pulmonary stenosis. Whereabouts do you think they're likely to be best heard? Refer to a standard text or cardiac auscultation audio tape in order to review these sounds, their location and timing. Okay, Ian, what we're going to do next is look at your jugular vein. Next we come to observation of the jugular veins and estimation of jugular venous pressure. This is a good non-invasive examination tool when you're trying to examine the patient's right heart. If you think about your physiology, the jugular veins empty into your right atrium and then into your right ventricle. So any problems with the right side of your heart is going to be reflected in your jugular veins and your jugular venous pressure. Jugular venous pulsations vary a little bit with inspiration and expiration, descending just a little on inspiration. So what you need to do is identify the highest point that they reach on the patient's neck. In Ian's case, they reach just around about here. And then you need to grab yourself a couple of rulers to clarify that estimation. Jugular venous pressure is generally quoted as being at such and such a number of centimetres above the sternal notch with the patient lying at such and such an angle. So what you do is you find that highest point of the jugular veins and lie a ruler along it and get yourself a second one, find the sternal notch, and measure up from the sternal notch to that ruler, and Ian's measurement there is 2 centimetres. So we'd quote his jugular venous pressure as being at 2 centimetres with him lying at 30 to 45 degrees. So Ian's JVP, or jugular venous pressure, was 2 centimetres at an angle of 30 to 45 degrees. Anything 3 to 4 centimetres and higher would be a sign of right ventricular heart failure.